All right, everyone, picking up where we left off with hormone replacement therapy. So similar concepts. We're going to talk about, a whole lot different other than just using it for different indications. Really, we're talking still about hormone replacement therapy. You could technically consider as oral contraceptives being under that branch, but really, when we're talking about this, we're talking about relieving menopausal symptoms and a couple other things. So 95% of all women will experience menopause between the ages of 45 and 55. So depending on how severe the symptoms are is really going to depend on what types of treatments we're looking at. Really, we're looking at symptomatic relief because menopause symptoms will fade once the patient is out of the menopausal period. So generally speaking, there's some cases where patients may have lingering symptoms, but generally speaking, the symptoms will go away eventually. However, during the menopausal period, perimenopausal period, it can be challenging to manage the symptoms with just other types of medications. Sometimes we do have to use hormone therapy, and we'll get to that here. But generally, we're talking about vasomotor symptoms, and when we use this term, basically that's the hot flashes we're talking about, which is going to be night sweats, sleep disturbances, kind of as the most common symptoms. Vaginal atrophy and mood swings are the other two common ones that can happen during menopause. So symptoms are most prominent during the last period of that that should be an of, not an or, of the perimenopausal period. There you go. Whoops. Hormone replacement therapy has a lot of risks and benefits. We'll talk about it. When it first came out, when people first started using estrogen products, it was really widely spread. Everyone was on it. Every woman within the realm of perimenopausal years was taking this, and then found out probably not the best idea for everyone. So let's talk about this a little bit more. So when hormones fade off during menopause, you can see kind of this perimenopausal period is what we're talking about here. So kind of leading into menopause and then postmenopausal, and the estrogen levels just being produced in the body slowly decreasing until you reach actual menopause. So hormone therapy does play an important role in symptom management. So we don't really use it for anything else, though. And I think that was one of the big confusions when it first came out. People were like, well, this estrogen supplements work great for all types of other things too. And well, it might not be that great. We talked about it a little bit with osteoporosis and how generally, even though it can work for that, we still prefer bisphosphonates for most patients, whether male or female. So anyway, the point is that hormone therapy is really effective, but we'll go through some of the risks in a second here. So who would you consider treating with hormone therapy? So perimenopausal women, of course, is going to be your criteria. But then beyond that, you're looking at moderate to severe vasomotor symptoms. And these are going to be people with systemic hormone therapy that you're going to consider. These people should have no history of breast cancer or cardiovascular disease. If the patient isn't really having significant vasomotor symptoms, or maybe they've had a brief period of vasomotor symptoms, but it's resolved at this point, you can try, and they just complain of vaginal atrophy. You can use a local vaginal only product that doesn't absorb quite extensively systemically, so you don't get as much potential for side effects with that. That's a good option for those patients. So that's kind of the general approach we take here, looking at for the vasomotor symptoms to get severe enough where you actually want to use something, or you've tried other options that are non-hormonal and nothing's working. And then for vaginal atrophy, you can use a local product. All right, so most of the time we're using estrogen. However, you can use combined products too, and I'll talk about why we might want to use one over the other here. But estrogen has some benefits in this patient population. First of all, it does relieve vaginal atrophy and relieves vasomotor instability. Basically, you're just replacing the hormone that's slowly being diminished by your body. And the idea is you can more gradually reduce the hormone. You can do it in a controlled environment by supplementing the estrogen versus just letting your body take its course naturally. And while some people may have no issue with that, there may be plenty of other people that do have problems with very big fluctuations in hormones where they need to be on a medication that's going to help them control that reduction versus letting their body do it naturally. With respect to osteoporosis and menopause, you do get a reduction in hip and vertebral fractures by about 25 to 50% respectively when it comes to estrogen therapy. when you're looking at people who have both perimenopausal symptoms and osteoporosis at the same time. Reductions does reduce rate of bone resorption, but doesn't restore overall bone loss. So it's pretty typical for an osteoporosis med. Cholesterol. This was once thought that estrogen therapy would actually help with cholesterol numbers quite a bit, but it actually wasn't shown to do all that much. There might be some number changes, but overall they didn't find any actual lowering of any type of heart disease overall. And so clinically, while it might lower the numbers, clinically the impact is unknown. There's a couple large trials, including a trial in JAMA that I link there. And also the Women's Health Initiative was a group, and I think I've mentioned this very briefly when we talked about osteoporosis, but the Women's Health Initiative looked at a number of different things affecting women's health, and one of them was hormone replacement therapy and the advantages of it. And there's some other, so that was sort of a meta-analysis that looked at a number of different studies, and they really didn't show any cardiovascular benefits with estrogen. Mood changes. It has been shown to help stabilize the mood changes associated with perimenopausal symptoms and sexual function. Again, we talked about the vaginal atrophy, and it does help with that and can decrease intercourse-related pain. So risks. Endometrial cancer risk goes up with unopposed estrogen. So with women with an intact uterus, you do not want to use just estrogen alone. And that's a big sticking point when it comes to this to remember as far as like testable material and just for practice. For somebody with a hysterectomy, estrogen alone is fine. If somebody has an intact uterus, you certainly want to consider, you can still consider hormone replacement therapy, but you certainly want to use a combination product with a progestin in it as well. And you generally are going to avoid estrogen products at all if they have a history of endometrial cancer. The risk does go up, and then of course if you have a history, it might be best to avoid it altogether. Breast cancer, there's not really good data about this. Is uncertain risk with unopposed estrogen. There's maybe a couple studies that show an increase in relative risk. Most experts would say that due to the likely increase in risk, whether it's clinically substantial or statistically significant, it's hard to say, but most experts would say to avoid it if you do have a history of breast cancer. Cardiovascular outcomes, we're going to circle back around to this when we talk a little bit more about the Women's Health Initiative. And general other effects, bloating, headache, breast tenderness are common. That's sort of the stuff we talked about when we talked about oral contraceptives. Same thing here. And unpredictable uterine bleeding if unopposed. So again, the same concept here as the oral contraceptives. A little bit different here because generally we'd have unopposed progestin being the cause of unstable bleeding or low estrogen doses being caused, and we'd increase the estrogen dose to stabilize it. However, if you give estrogen alone, you can get some unpredictability there. Now, the issue with this, of course, is we aren't going to be giving these products to people with uteruses. So generally speaking, you're going to use a combination product, and then you aren't going to have that issue, right? All right, so the Women's Health Initiative, just because I mentioned it a couple times, here's a slide on it. The risk benefit is, and the number of things that they primarily looked at is on the left side here. So you can see heart attacks, breast cancer, strokes, blood clots, hip fracture, colon cancer, and dementia. So kind of all over mostly focused on cardiovascular, but sort of all over the spectrum here. And as far as this trial, so this, again, the Women's Health Initiative looked at a ton of different data and compiled a lot of trials. It's basically a meta-analysis, if you want to think about it that way. And they looked at trials that included conjugated estrogens, and we're going to talk about the specific products here in a second, but that's the most common form of estrogen on the market, and medroxyprogesterone, which is, of course, a progestin product. In women ages 50 to 79, primary prevention of cardiovascular disease. And there was some controversy here too. So now when we look at this, we see with heart attacks, the risks did increase by about 29%. So 7 more cases per 10,000 women versus not taking it. Breast cancer had an increased risk. Stroke had an increased risk. Blood clots was a substantially increased risk, which is what we'd expect with estrogen. Hip fractures decreased. Colon cancer decreased. Oops. And dementia actually increased somewhat too. So again, when this drug was first being used primarily for this. There was some maybe early preliminary data that maybe showed positive things for these, and then the more we studied it, the more we realized, well, actually, the evidence shows that it might be more harmful than good. So that's why, generally speaking, we try not to use hormone replacement therapy if we can avoid it. However, there are symptomatic episodes where patients are really having problematic symptoms that are disrupting their daily life. And in those cases, a short course of hormonal therapy is indicated, but just be aware of the risks associated with it. Okay, what about progestin? So you decrease the risk of estrogen-induced irregular bleeding. So you kind of the two together work well to stabilize everything, and you also reduce the risk of endometrial hyperplasia and therefore carcinoma. You protect a little bit against breast cancer and enhance estrogen prophylaxis and osteoporosis. So everything kind of balances out if you add a progestin to it. So it leans you towards wanting to probably consider combination products for most people. General adverse effects: bloating, weight gain, irritability, depression, unpredictable bleeding in the first 8 to 12 months of therapy. So again, not too much different than our oral contraceptives. And really, these are very similar. I mean, we're looking at an estrogen plus a progestin. The only big difference is you usually aren't using ethinyl estradiol, although some drugs certainly do. So I'll show you the drugs here in a couple of slides. As far as hormone therapy treatment, the drugs come in a lot of different products. So multiple delivery routes are available. There's oral, patches, there's vaginal products, some of which absorb systemically and some of which just stay in the vagina, which would treat local symptoms. And of course, some absorb systemically. Those would treat systemic symptoms. So you have to be careful when prescribing the vaginal products. With unopposed estrogen therapy, you get endometrial hyperplasia and cancer possibility, so even after as little as 6 months of therapy. So in any woman with an intact uterus, again, combination product. Women who have undergone hysterectomy, you don't really need to give a progestin because you're giving something that is not all that beneficial. Yes, you could make the argument, like if you go back to our other slide, that you do get some protection against breast cancer, maybe some osteoporosis benefits. But ultimately, you're providing another drug that might have additional side effects to it. And the major side effects associated with estrogen are related to the uterus. So if that's gone, we don't really have to worry about it as much. So it probably makes most sense in a patient without a uterus to just use a plain estrogen product unopposed. All right, here's some estrogen products out on the market. And again, there are some estradiol products out there. You can see there's estradiol. The one product that's different, well, the group of products that's different, I should say, are the conjugated equine estrogens. So you see CEE here abbreviated. Conjugated equine estrogens, I think we talked about this briefly during osteoporosis, but it's the product with Premarin and Prempro and all the pre-products out there, which were the big brand names of estrogen when it first came out. And it's isolated from pregnant mare's urine, so a pregnant horse's urine, and that's how they extract the drug. Actually, it's kind of an interesting and somewhat gross process, I think. So with unopposed estrogen, again, find any person post-status post-hysterectomy. Transdermal estrogen is a good option for women intolerant of oral products. There's some argument that there's a lower VTE risk, but as we showed with we talked about with Ortho Evra, you have possibly an increased risk with that product because you get an increased exposure even though the overall dose is lower because it does absorb very well transdermally. You can do estrogen plus a cyclic progestin. So you get continuous daily estrogen and then progestin for 10 to 14 days per month. So it's very similar to the female cycle with a withdrawal bleed each cycle while the patient is still in that perimenopausal or even premenopausal period. Estrogen plus continuous progestin is also common without interruption, and then you get a regular menstrual cycle for the first 8 to 12 months until you eventually would get through menopause ideally. Hormone regimens, there's a number of different types, and those are just some examples. It's really similar to oral contraceptives in the sense that there's a lot of products on the market, and you really need to tailor your dose to your patient's symptom response. So instead of, in the case of oral contraceptives, tailoring your product or changing your product based on your patient's side effects, in these cases, a lot of times we are really targeting symptomatic relief. So you really want to get by with the lowest dose possible that's still going to give your patient symptoms. So it's very similar to other aspects of medicine, right? We don't want to overdose somebody if we don't need to. So some regimens you could think about: estrogen plus intermittent progestin, continuous estrogen daily, 3 days on progestin, and 3 days off. This is a really rarely used form, so don't really pay much attention to this. Generally speaking, you're just going to consider one of the products I just talked about before, not the intermittent one. Monitoring, monthly self-breast exams, annual mammographies, pelvic exams, evaluation of vaginal bleeding. Those should all be kind of common sense monitoring things. Duration of therapy, you want to use the lowest dose, again, for the least amount of time. Check symptoms after 3 months, and then if still having symptoms, you could have them back in a year, or you could check more often than that. There's no reason why you couldn't bring them back in another 3 months. Discontinue if asymptomatic, and limit the therapy to 5 years total. Patients shouldn't be in, it's possible, but they shouldn't generally be in menopause for more than 5 years. And if they are still having symptoms after that, we might need to look into maybe some better long-term options than hormones. And that's a perfect segue into this next slide. So selective serotonin and norepinephrine reuptake inhibitors, our antidepressants, have actually been somewhat studied in this for treatment of menopausal symptoms, and these mostly work for our vasomotor symptoms, so to prevent hot flashes. So venlafaxine is probably the most frequently studied one. However, there's a lot of SSRIs that are studied too. Fluoxetine, paroxetine, sertraline all have indications. So beware of rebranded products. So for example, there's products called Brisdel and Serafem. I think Brisdel is a rebranded venlafaxine, or maybe paroxetine. I can't remember. Serafem is a rebranded fluoxetine. Really, what these drug companies are doing is they're rebranding the product at a different dose than what's commonly used for depression. So, for example, let's say fluoxetine comes as a 20 milligram and a 40 milligram. Well, Serafem might say, well, I'm going to brand this as a 25 milligram product. So they get FDA approval to be a brand name, when in fact you could just prescribe somebody 20 milligrams and get the same effect. It's really nonsense. So just be careful not to prescribe the brand name and end up, making your patient pay a whole bunch of money. If they don't know any better, they might not, and the pharmacist doesn't catch it. It's really falls on your shoulders to make sure you're prescribing generic in these situations. But any of these are probably okay. They all kind of work the same way. No one really knows exactly what the mechanism ties into. Something, obviously it's serotonergic, and the norepinephrine component might make a little bit more sense, centrally active with respect to like vasomotor outflow maybe, but just plain SSRIs, I don't really understand it personally, and I don't know if anyone really has a good grasp on the mechanism behind that. There are some herbal natural products. There's soy isoflavones. These products have molecules that act very similar to estrogen in the body, so it's not a whole lot different there, but it is an over-the-counter thing. Evening primrose oil, is kind of an old wives' tale. From what I've read, there's no clinical evidence for using this. Black cohosh is another product that has some similar estrogen-like activity and it has some mixed evidence for its use. Bioidentical hormones are done by specialty endocrinology practitioners might have some sort of agreement with them. There are specialty compounders that do these products, maybe specialty compounding pharmacies that make them. It's going to be unusual to find somebody that prescribes them. You might have to get a referral to do that. But just in case you're wondering, it's basically just like estrogen. I think they just use human product versus horse product, and so somehow they get human hormones. And again, I don't really know much about the process, so I'm not going to go into detail, but it does exist. I've seen it in a handful of individuals. Other things you can try: clonidine has been shown to maybe work for the vasomotor symptoms. Gabapentin and Magestrol also. Gabapentin, again, kind of along the psych side of things, working in the central nervous system and somehow decreasing vasomotor outflow, perhaps. Back to Magestrol. We didn't really talk about this ever, but it's kind of like a synthetic progestin, so it doesn't really necessarily belong on this slide probably, but it's not technically, so I threw it in here. These all have kind of mixed data for their use. They're probably worth a try, especially clonidine and gabapentin, especially if you have a patient with high blood pressure. It might be worth giving a shot to. All right, since I skimmed over breast cancer during oncology, I do want to just cover it a little bit. So breast cancer is the most frequently diagnosed of all cancers, leading cause of cancer-related death in women, and especially women 40 to 49. And usually you're looking, just like most types of cancer, you're looking at combination therapy, so surgery, radiation, and chemotherapy. Stages 1 and 2, just like most cancers: small tumors, high cure rates. Surgery alone is fairly effective for solid tumor cancers. And lymphatic involvement, if it does happen in stages 1 and 2, you're looking at cycles of chemotherapy. So cyclophosphamide and methotrexate, 5-FU or 5-FU doxorubicin cyclophosphamide. These are the abbreviations that they use commonly. And then there's some alternate regimens there. I'm not going to test you on the chemotherapy regimens for breast cancer. What I do want to focus on is talk about hormone manipulation a little bit, and then we'll there will be a couple of test questions about some of the mechanisms of action, kind of similar to the prostate cancer questions for the men's health stuff. I might just ask you a few mechanism of action related questions. So tamoxifen is a selective estrogen receptor modulator, or SERM. So it's similar to the drug Evista or raloxifene that we talked about during osteoporosis, but it just binds to different receptors. It binds to tumors and other target tissues, so you get decreased DNA synthesis and inhibits estrogen effects, essentially. Competes with estrogen for binding. It's not cytotoxic, but it is cytostatic, so it causes the tumor to prevent new growth and eventually will augment whatever other types of therapy you're offering. It's relatively cheap as far as chemo goes, so that's good. Side effects are kind of what you'd expect from an estrogen-related medication. You can see them there. It may actually induce menopause too. And this is just another thing about what SERMs do. Hormone manipulation continued. Drugs called aromatase inhibitors are useful for breast cancer. What they do is they block the enzyme aromatase, which prevents peripheral conversion of androgens to estrogen. So contraindicated in premenopausal women with intact ovarian function. The reason is stimulate increased estrogen function due to negative feedback. And when it comes to ovarian suppression, you end up again with this negative feedback loop that's actually causing an increase in estrogen function. So it's actually problematic in that situation. Some examples of these medications are listed there. If you remember, like Ozols, should be okay. $15 to $20 per pill. They're kind of pricey. There's no data to suggest any's better than the other. Usually you start one of these after you do tamoxifen. So you do tamoxifen course and start a aromatase inhibitor. Side effects. CV side effects can be quite high. Osteoporosis risk, can get myalgia and joint pain too commonly. Some other hormone replacement therapies involve ovarian suppression. There's a couple medications listed here, and basically monkeying with releases of LH and follicle stimulating hormone. Estrogen receptor antagonist, there's one medication called fulvestrant, or Faslodex is the brand name. It causes a dose-related downregulation of estrogen receptors and inhibits tumor growth. It's an injection once a month, and it's kind of expensive. So it's just something that it's a third option for hormone manipulation with patients with breast cancer. Stage 3 and 4, just like a lot of cancers, once you get into later stages, it's often palliative and it's challenging. You can definitely still use the 1 and 2 stage medications. However, you get more challenging as far as a response rate goes. Metastatic cancer is usually not beneficial from hormonal therapy because you've kind of expanded beyond the realm of the hormone-specific tumors. And in that case, it just doesn't really work. So you need to target other more broad spectrum chemotherapeutic regimens. And that's it. So with that being said, again, the chemotherapy questions, I'm just going to ask some mechanism of action, a couple probably mechanism of action related questions, nothing too crazy. Don't get too worked up about it. And with that, I'll see you guys Monday. Sorry for the delay in this lecture. It's kind of been a crazy week. I had family in town and a sick kid. So, but it's up now. So enjoy while you can and enjoy your weekend. Thanks.